Good evening, everyone, and thanks for joining us for tonight's annual immunisation update for GPs 2026. It's a cold and dark night outside, so good to be in front of your screen. Let's begin by acknowledging the traditional custodians of the country across our region and their deep and enduring connections to land, water, culture, and community. I pay my respect to elders past, present, and future, and extend that respect and a warm welcome to all Aboriginal Australians joining us this evening. Welcome, everyone. So, tonight's webinar is incredibly topical, and it's presented in partnership with the National Centre for Immunisation Research and Surveillance, or NCIRS, as we all know it. And we're delighted to be joined by our guest speaker, Dr. Archana Kerala. Archana is a pediatric infectious disease specialist and general pediatrician who joined the NCIRS in 2018. I do remember her from COVID presentations back in the day. Archana is part of the New South Wales Immunisation Specialist Service team, which reviews children who've experienced an adverse event following immunisation. She's also a clinical lecturer at the University of Sydney and is interested in public health and surveillance. With that, I'll hand over to you, Archana. Thank you.
Thanks heaps, Jenny, and welcome everyone. I'm just going to share my slides. All right. Okay, so just wanted to say thank you so much for having me. I'm going to be talking about respiratory vaccinations and also just give you a little bit about meningococcal disease and perhaps some tips on some NIP refreshers. Just like to acknowledge a whole lot of people that work at NCERS and through the PHN who collaborate with us and really think about these vaccines and why they're there and how to communicate that to you all. All right, so I'll talk about flu, respiratory, RSV, COVID, pneumococcal, and then a little bit about meningococcal later on. So let's think about flu. So this is a graph. It gets produced every year by the Australian government, and it looks at, if you can see the dark blue, the light blue line, so the dotted line is 2025. So that was a biphasic flu season. So lots of flu during the winter period, but then another extra tail end of flu during the summer period. And you can see this is now New South Wales, and it conveys the same message in that there was a lot of flu in the usual period between June and October. But then again, there was this mild peak again in December and tailing into February. You can see last year it was mainly flu A, but then there was a large component of flu B as well. And when we think about flu A, and this is really important when you think about the vaccine, there are two different strains of flu A that we need to consider. So the H1N1, and that was predominant over the winter period. But then it was the H3N2 or the K clade that circulated during the Australian summer. And this is just a reminder to you all. We all know that flu can cause severe complications. We know that children under the age of 5 are more vulnerable to flu, and that's because they have an immature immune system. They have smaller airways that become inflamed and clogged with mucus more easily. And in particular, for children, when they get the flu, they're at increased likelihood of cerebral irritability. And so that's why you can see over there in the box that neurological complications are far more common in children compared to adults. Children with pre-existing medical conditions are at higher risk, but I'll show you another slide that all children really can be hospitalized. But so children under the 5 more vulnerable, older adults are actually at the highest risk of dying from flu. And this is because of frailty, a phenomenon of immunosenescence that you all are aware about, where the immune system also ages as we age. And they also may have an altered airway due to smoking, COPD, or various other reasons. So this is a graph looking at in pediatric influenza admissions, and it's from our PEDS website. And PEDS is a surveillance of all tertiary pediatric hospitals around Australia, and they look at who comes into hospital with flu. And you can see there that younger children are more likely to be hospitalized, but in light blue, it's children who are admitted who have an underlying medical condition or a comorbidity. In purple, it's usually healthy children with no or unknown comorbidities. So although those who are with medical comorbidities are at higher risk, most children who get admitted to hospital with flu are healthy children. And that's really, really important when we think about immunization for all. Now, in terms of what happened last year, so we had a quadrivalent vaccine last year, two flu A's and two flu B's. And just looking at the effectiveness, and that is really dependent on what is actually circulating and how good of a match it was to the prediction or to the vaccine containing strains. So against general practice visit, it was 56%, a little bit higher with flu B compared to H1N1. And against hospitalization, it was around that 50%, again, much higher in flu B. And that's really important because we saw some pretty nasty ICU kids in ICU with flu B. So it was a middle of the range vaccine. We know that the flu vaccine isn't a silver bullet, and we expect the effectiveness to be around 40 to 70%. But really, when we think about how effective a vaccine can be, it's not only the vaccination of the individual, but it really requires quite good coverage. And we know that since, the highest coverage was actually in the first year of the pandemic in 2020, and because of all the restrictions, we actually had no flu circulating. But since then, the coverage has been quite suboptimal. It's always been the highest amongst the elderly, and within the 10 to 20% for other age groups. Now, this is this year, 2026, and it's up to May 2000, up to the 16th of May. And you can go onto our website and you can see it, and it gets updated around fortnightly. So you can see in real time what is the coverage. You can see that the table is quite detailed, and it splits the pediatric age group to year by age for those under 6 years of age. And that's really to better understand the vaccine coverage of perhaps the live attenuated influenza vaccine that's registered from 2 years onwards. So you can see and you can compare New South Wales to other jurisdictions, and we're doing okay in our elderly, but still we still have a little bit of work to do, especially in the under fives and the childhood age groups, and we know that they're the highest transmission of flu. And interestingly, and I note this now, is that in the UK, they recognise that kids with flu are primary transmitters. They actually start their flu season, they actually start with vaccinating children before they vaccinate adults, just because they want to reduce that transmission. So it's really upon us and to ensure that our children are also vaccinated. It helps the whole population. Okay. So you've been giving out the flu vaccine for a month and a half now, or even 2 months, and perhaps 2 months, 2.5 months. And you'd be aware that it's a trivalent vaccine. So there's no more B Yamagata strain. And that's because during COVID, it disappeared. So there's no circulation of B Yamagata. Whether it'll reemerge, it's unknown, but we haven't been able to detect it since then. So you also know that there are two types of vaccines. So they're grown in different mediums. So there's the egg-based flu vaccine and the cell-based flu vaccine. And you can see that they both contain two flu A strains, so H1N1 and an H3N2, and one B strain. there's always a slight difference on the strain. You can see, it's Missouri. The Missouri one is the same, but there's a Singapore versus Sydney, and that's because of the way the virus is grown in these different mediums, but they're very, very close and they have the same effect in terms of immunity. So I talked to you about the K clade. And last year, so 2025, our H3N2 vaccine was actually the Croatia strain, and that was used in both the southern and the northern hemisphere vaccine. And they knew that, and when they reanalyzed it, they showed that in fact, it was quite different to the K clade that was circulating, and perhaps the vaccine wasn't a great match for the circulating strain. And you can see now, and I show you here, that it's been changed to the Singapore or the Sydney strain. So that has been a conscious decision because of the K clade circulation. Okay, so this is a busy picture, but I really like it. And that's because I talked to you about the 2025. So that is the strain that was in the 2025 vaccine. And you can see on this phylogenetic tree that it lies around here. But then you can see that the K clade is in orange, so it's all the way over here. So it's quite different in terms of its antigenic differences from the vaccine strain of 2025. And so you can see that the Singapore and the Sydney strains are much closer to the clade. And so we hope that it'll be a much better match. So, influenza recommendations, and this is what you know. We know that in terms of recommendations, it's recommended for everyone over the age of 6 months. In terms of the NIP funding, there has been no change from 2025. So all Aboriginal and Torres Strait Islander people aged 6 months and over. For all children 6 months to less than 5 years, both healthy and those with underlying medical conditions. For pregnant women, for all people aged 65 years and over, and all individuals aged 6 months and over with specific medical risk conditions. And this is a great table that I hope you've all seen from the respiratory workbook that New South Wales Health releases, the toolkit, sorry, respiratory toolkit. And I like this better than the ATAKI statement or the handbook because it actually it's a lot clearer and you can see clearly in green which vaccines are NIP funded. You can also see below that New South Wales, and this is something that you all know, has funded, so state funded in 2 to less than 5 years. But since last Friday, they have now funded from 2 to 17 years. So it's expanded to less than 18 years just from last Friday. So it's updated in a little memo, and you can see that a single dose should be offered to all healthy children 2 to 17 years, do not have a contraindication, and it is now funded. Okay, so now when we think about the flu vaccine, most people only require 1 dose per year, but there are certain populations that we need to make sure that we give 2 doses. So for children, and this is a change from last year. So in healthy children aged 6 months to less than 2 years, if it's their first time receiving a flu vaccine, they need to receive 2 doses at least 1 month apart. But those children with an underlying medical risk condition, it's expanded to less than 9 years. And that was consistent with the years before. But remember, it's only that first time that they receive the vaccine. And the second dose should be given at least 4 weeks after the first dose. In transplant recipients, because we deem them as immune naive, so we see them as potentially like the children immune naive, so they should also receive 2 doses the first time that they receive a flu vaccine after a transplant. And for travelers, don't forget about them. It's obviously shown that the second spike was due to the introduction from travelers from the Northern Hemisphere. So we want to protect them. We know that the injectable vaccine lasts for around 6 months. So if they're traveling to a place where flu might be circulating, they should receive the southern vaccine for the second time prior to travel. And also that different brands of the flu vaccines are interchangeable by type. So if someone received a cell-based first up and you've run out of it, they can receive the egg-based. That's not a problem. Okay, so I just wanted to touch on FluMist, it's the life attenuated flu vaccine. It's used extensively overseas. In fact, since 2003 in the US and 2013 in UK school-based programs. I've already flagged to you that it's registered from 2 to less than 18 years, and it's available in the private market. This slide, obviously, I created my slides prior to Friday, so I've said that it's funded from 2 to less than 5 years, but it's now funded up to 17 years. There is an expiry date, as you probably all know, so we really want to make sure that we administer it before the stock expires. It's not approved in Australia for 18 to 49 years old, and that's because of the lack of studies supporting effectiveness. But if you Google it, it's actually registered in the US up to 50 years of age. So perhaps when we get more data, it is something that might be expanded in terms of age group. And most importantly, in kids with asthma and wheeze, it doesn't exacerbate their symptoms or disease. So how does it work? It's pretty straightforward. It's been made to replicate at a lower temperature. And it's been modified to be highly mucosally absorbed, right? So you can see that it's cold adapted. So it replicates in the nose and airway, and it's very inefficient in replicating in the lung. So that's different to the wild type virus. And we know because you're giving it into the nasal mucosa, not only does it stimulate your adaptive immune response in your body, but also that mucosal adaptive immune response, including IgA, and it results in protection. And in fact, when you compare it to the injectable vaccine, the duration of protection is actually longer because you can even go up to 12 months. When you compare it, so this is a busy slide, but I think it's an important one, and there's lots of references for you to look at if you're interested. And it compares the LAIV versus placebo, so no vaccine, or the LAIV versus the IIV, which is the injectable vaccine that we've been using for many years. You can see that it's much better than placebo, which is what we hope. And then when you compare it to IIV, we can see that for part and parcel overall, it's quite equivalent. So that's really important to know and to be able to explain that to your patient cohort. Now, in terms of safety, it's a very safe vaccine if you give it to the right population. A lot of kids may have a runny nose, and my kids went and got it this weekend, and they had a slight runny nose that was stopped within a few minutes, actually. They might experience a headache, vomiting, muscle aches, and that's fair. We've given them a vaccine. They need to have develop an immune response to the vaccine, and they might some may experience a low-grade fever. But there are contraindications, and I think it's really important to remember these. Aged under 2 years, not registered anywhere globally, and that's because there has been an association with increased wheeze risk in that population, and I'll show you some data in the next slide. Those with moderate or severe immunocompromise, and you can look at the Australian Immunisation Handbook for those details, and it's usually those on immunosuppressive medications or have an immunosuppressive condition. And that's because it is a live vaccine and there is theoretical concern of disease. Those taking salicylate therapy, like aspirin, and that's because of the association with flu and aspirin causing Ray's syndrome. And again, this is a theoretical concern because it is a live virus. And of course, those with prior anaphylaxis to active substances or any of the excipients as per all vaccine contraindication. So here's some information on why it's only registered for over 2 years. And that's because in the studies, it was associated with an increase in medical significant wheezing. And the in the paper, it's kind of acronymed as MSW in infants aged 6 to 23 months receiving LAIV compared to the injectable vaccine. And MSW was defined as the presence of wheeze on physical exam. They needed a prescription for a bronchodilator or that they had respiratory distress or hypoxemia. And this was monitored up to 42 days following vaccination. So you can see here in the red box are the ages 6 to 23 months. And you can see, although it's quite small, that you can appreciate that it's much higher than when you compare it, and especially the white boxes, which is the LIV, which was much higher in that age group compared to older children. And so two take-home messages: don't give it to under two. It can potentially increase their risk of wheeze, but that a child who's over two who has a history of wheeze or asthma, it doesn't. So they can receive that. Now we've had a number of emails to us where it's been inadvertently administered to younger children. And we advise that there's no need to repeat the dose. It will be immunogenic and they will develop an immune response to the vaccine. But if it's their first season and they need that second dose, then it should be an injectable form unless they've turned two during that time period. Yeah. Okay, this is just some global data, and I explained to you that the UK has had this school program for a while, and they did a pilot study in 2014 and 15 where primary school age children were given the nasal spray vaccine, and they found that in that cohort, so in those primary school age children, that there was a reduction in GP visits with flu-like illnesses by 94%. In the same cohort, there was a decrease in A&E or ED presentations with flu-like symptoms by 74%. And there was a decrease in 93% of hospital admissions for flu-like symptoms. But in addition, there was a decrease of 59% in adults presenting with flu-like symptoms. So not only was it effective in protecting the children who are vaccinated, but it had a knock-on effect to the community and into adults. So this is just a myths and facts. It doesn't revert to wild type flu and cause disease, and so no reversion has ever been observed despite 40 years of trials and millions of doses. And for it to revert, it would require multiple independent genetic mutations, and that's an extremely unlikely event. Another one is that shedding of the virus causes transmission and illness, but shedding is not equivalent to transmission. And I did an extensive literature search and also talked to my colleagues, and there has been only one asymptomatic transmission that has ever been documented, and that didn't cause disease. Live vaccines can cause serious adverse effects. We know that it's well tolerated in those who are eligible. And LAIV is only effective when the vaccine strains perfectly match circulating strains. But we know that, that it induces mucosal and cellular immunity, similar to natural infection. And so perhaps provides a better protection against antigenically drifted strains. And this is, you'll have these slides, and it's a comparison of the two vaccines, and you can have a read of that. Okay, and I also just wanted to let you know, and you're probably well aware, that there's lots of resources on our website, free to access, and we welcome you to have a look and have a think about flu. All right, I'm just going to have a sip of water, and then I'll talk about RSV. Jenny, were you saying something? You're on mute.
I am. Sorry about that. We've got two questions in the question box. One, I think an attendee just missed out on some of the detail. They're saying for a child who's receiving FluMist as their first flu vaccine, should they receive the second dose as an injectable? Is that correct? And I think that was the case where a child under 2 was inadvertently given FluMist.
Yes, that's correct. Yes, if they're still under 2,
Yeah.
don't repeat the FluMist.
Yeah, and we had a question or a comment from Kate Green about the expiry dates on the original batches of flu mist gave a quite short utility, expiring on the 5th of the 6th, 26, but private stock obtained expired later on. And then it was, do we know if the government stock will have expanded expiry dates and can still be ordered?
I don't think so, but I'm not 100% sure.
Right, okay.
Yeah.
Um,
Okay. All right.
it.
I might continue and then we can touch base on the other questions. Fantastic. Yeah. So I'm not sure in terms of what may come in as a second batch, but we can take that on notice and answer that. Okay, so respiratory syncytial virus or RSV. This is the notifications in New South Wales, and it's by age. So you can see that the y-axis of the first graph is in the hundreds, and that is showing ages 0 to 4. And then you can see below that the y-axis is 20 by 25, and that's in ages up to 90. So you can see that children have a large burden of RSV, usually in an immune naive host. They get that RSV and they can develop pretty severe bronchiolitis. And then, but we also, and this has been recognized over the last 10 years, that adults can develop pretty severe pneumonia with RSV that require hospitalization. And the older you are, the higher the risk of consequences from that. And this is a graph that we created, and you can have a look. And this is incidence, right? So hospitalization per population, so rates. And you can see in the red line, those are our Aboriginal and Torres Strait Islander people, and both in the pediatric setting and the elderly setting, they are at higher risk of hospitalization from RSV. And you can see both curves. It goes, your highest risk of hospitalization is when you're very young and very old. Okay, so let's think about infants and then we'll talk about adults. So, RSV not only causes hospitalization in infants, but it does have long-term consequences. There's this study that I show time and time again that shows that if you've had an RSV infection during infancy, and that's red, versus one that you haven't, you're at higher risk of childhood asthma. And it seems to be more an non-atopic asthma that you're at higher risk of. So that is a pretty significant consequence through childhood. And so what are we doing in terms of our immunization program? And this is just a reminder that in infants, they are immunized through passive immunization, right? So we either give a Brisvo, which is a non-adjuvanted RSV vaccine, to mums so that mums can produce antibodies, and the antibodies are transferred via the placenta to the baby, protecting the baby for the first 6 months of their life. Or we can give exogenous, so monoclonal antibodies. So if the baby's born and the baby hasn't received adequate antibodies from mum, or is very ill and has depleted the antibodies, then we can give a monoclonal antibody with a long half-life so that they also are protected for 6 months. And this can be repeated in the second year of life for vulnerable children. In adults, it's all about active immunization. So we're giving the vaccine to the adult and they're producing their own immune response. So the new thing that you all probably are aware is that the RSV vaccine is now, we recommend that it's vaccinated in every pregnancy. So last year it was still, we were still unsure and we were thinking about, protection. But since this year, the recommendation is just like the whooping cough or pertussis vaccine, we want to vaccinate every pregnancy so that maternal antibody is boosted and it transfers to baby for protection. And in the UK they recommend that too, and we know that in non-pregnant adults aged 18 to 49 years, it showed no increase in adverse events after revaccination versus just having one. So there's no anticipated increased adverse events in this population. This is Australian data looking at the 2025 impact, and this is comparing to the incidence or the cumulative RSV admissions in 2024 and looking at those pediatric sentinel hospitals. And you can see in 2024 is in red, that the admissions were higher than 2024, and there was a discernible reduction in admissions, especially the younger you were. And when you calculate effectiveness against hospitalization, maternal vaccine came at 80% and nirsevimab at 87%. So they're both together really, really are quite effective in protecting our young babies. So this is, again, just a reminder slide. Nothing is any different. Neonates and infants aged less than 8 months whose mothers did not receive the vaccine in pregnancy or didn't have an adequate time to produce an immune response, so vaccinated less than 2 weeks before delivery. Infants with risk conditions for severe RSV disease, regardless of their maternal vaccination status, for example, kids with chronic lung disease, and infants who are born to mums with severe immunosuppression because their mothers wouldn't have produced adequate antibodies. And then there are a small cohort of children where they also are recommended a second or subsequent vaccine who have a certain risk condition. And just as an FYI, it's not registered for years 3, 4, or 5. There really isn't much data in terms of dosing in that age cohort. And the nirsevimab is funded by states and territories, but as you all know, it is within the Australian Immunisation Register, and we hope that you all are putting it in and documenting the doses that you're giving. Okay, so now in older adults. And this is one of my colleagues. He's doing a PhD on RSV, and this is data from Queensland. It's unpublished in the manuscripts in preparation, but it shows beautifully, and this is local data, that hospitalization increases acutely after that 50 years of age. So you can see that it is a plateau, and then there's that exponential rise. And he also showed, again, that RSV death, not only, so it's the older you are, the more likely you are to die from RSV, but also if you have a comorbidity, for example, if you're immunocompromised, you have cardiac disease or chronic renal disease. So both age and age plus an underlying medical conditions puts you at higher risk. And we know that since a couple of years ago that Arexvy Brisvo has been available for older adults on the private prescription, but there's been a substantial cost, so 300 to 350 per dose on a private prescription, and there's been very limited uptake. So when we calculated coverage between the 1st of May 2023 to 2025, that only 3.5% of adults aged 75 years and above received the RSV vaccine, and it was only 1.2 adults aged 60 to 74 years. So having it on the private market really didn't make any dent to our adult population. But you all know that the announcement was made on the 19th of April that the RSV vaccine has now been funded from the 15th of May for older adults. And I see that as a huge win. That is super. When you look at all those data that just shows the risk of hospitalization and death, I think it's a great thing that we now have a funded RSV vaccine for our older Australians. So who is recommended and who is funded? So green indicates groups are funded under the NIP, right? So adults aged 75 years and above, and Aboriginal and Torres Strait Islander aged 60 and above. But if you're non-Indigenous and you have a medical condition that medical conditions, you are recommended, but it's not funded. And you can see in the graph that you're at higher risk, but it's not funded. So that's still in the private market. And if you can consider if you're an adult aged 60 to 74 and adults aged 50 to 59 years who have a medical conditions. And there's a little kind of asterisk here because it's only Arexvy that can be given from 50 to 59 years because that's the only vaccine that's registered for that age group and not Brisvo. So yeah, so just a reminder, 75 years and plus, if you're an Aboriginal and Torres Strait Islander elder, 60 years and above, that's funded. And just as an FYI, WA have also funded all adults aged 65 years and above living in residential care homes. So if you have someone that has come from WA, they might kind of quote this, and that's the reason why. Okay, how effective is it? Like, why do we give it? Well, there's a 60 to 80% reduction in hospitalization, 70 to 80% reduction in ICU admissions or death. It works in immunocompromised adults and in adults with COPD. And we know that it works, one dose works very well, even up to 3 seasons. And we don't have data after 3 seasons because it's a relatively new vaccine. And so we'll just have to see if an additional booster is required. For the moment, just one vaccine. Okay, this is a beautiful graph that I like, and there's a link to the citation. And you can see that in the UK, and I just show you to the graph B, that in the UK, they funded it between that age group. I think it's 74 onwards. I can't remember the exact age group, but they funded it for that age group. And then the incidence of RSV really reduced. So I thought that was a pretty amazing graph. Okay. If you go to our AusVac safety website, it shows you the safety of the vaccine, and you can see that it is pretty much on par with other vaccines in that mild commonly reported adverse events occur, but that they occur kind of at the same rate as you would with other vaccines, and they're not increased if you give it concurrently with another vaccine. This is important to note, Guillain-Barré syndrome. There is an association with the RSV vaccine with Guillain-Barré, but we know, like flu, like other viruses, that the infection itself may trigger GBS, particularly in older adults, so it's important to protect them. The risk of GBS following vaccines is extremely rare, and you can see here that it's 9 per million doses of Abrysvo, or 6.5 per million doses of Arexvy, and that's excess the doses. So in essence, if someone does come with Guillain-Barré, it's important to investigate. If they develop Guillain-Barré following another virus, it's not a contraindication for RSV vaccine. So please still consider it. It's a common question that comes up to an end with someone has had Guillain-Barré for some other reason. Is it a contraindication? And it's not a contraindication for any of the vaccines. All right. So just some take-home messages from the 15th of May. A single dose of the RSV Arexvy will be funded under the NIP, and I reiterate that it's the Arexvy, and I always think XVY, end of the alphabet, so it's for the older adults, because Abrysvo is not funded for older adults. But both are quite protective against severe RSV. This is a good summary slide, and I'll leave it with you to have a look in your own time. I also wanted to highlight that there are other TGA registered immunization products. So we now have a TGA registered mRNA RSV vaccine since March 2025, not currently available in Australia, but it's an mRNA vaccine which ends up making the fusion protein, and you develop immunity through that. And there's also clesrivimab, which is Influenza, which is another monoclonal antibody, and that's also been TGA approved in March 2026. So just watch this space. I might be talking about it next year. All right, so that is RSV. I'm just going to talk a couple of slides about COVID, and then we'll go from there. Okay, so COVID is still here. It's an endemic virus, right? So we were all worried about the pandemic, but its pandemic has been stepped down. It is now endemic. So it's still there. It still causes quite a lot of disease, especially in the elderly, but we're learning to live with it. Now, when we always remember when we used to talk about all the variants and the subvariants and the this and then that? Well, there's lots of different subvariants that are still circulating, and at the moment it's the BA 3.2 that's now become the dominant circulation. I love this graph because it always so pretty, like, it looks like splashes of paint. But yeah, just to show you that the COVID virus is constantly mutating. And the 2026 COVID recommendations remain unchanged. We have the LP 8.1 vaccines that are currently available, and it's funded for all eligible people. This is what it looks like. You can see the LP1 vaccines, they've from 6 months onwards, and the one that you'd commonly use is the green one. And this is a busy slide, but you're all GPs, and I love showing this to you guys. In that, when you think about, so what happens is that as a new subvariant vaccine comes up, we need to check that it actually works against the circulating variants. You can't really do that with effectiveness studies. It's very, very hard. So you use immunogenicity studies or neutralization. So what you do is you take blood from people who haven't had the vaccine, and then you vaccinate them, and then you take serum from them afterwards. And then you see how much protective or neutralizing antibody that person has produced against viruses that you stimulate in the lab. Right? And you can see here, this is the BA 3.2, which is now the dominant strain, and that LP 8.1 vaccine that Pfizer has produced, it does produce pretty good antibodies against the BA 3.2, and you can see that it produces pretty good antibodies across the board. So it's that LP 8.1 vaccine. So when someone asks you, does the vaccine work? Because everyone's a bit tired of COVID, no one wants a vaccine, right? And you can say that there are still mutations, there are lots of subvariants that are circulating, and it's shown to be protective. And most importantly, it's shown to be protective against older adults. So this is what I try to hone in, that people who received a COVID-19 vaccine more than 12 months ago are almost twice as likely to die from COVID-19 compared to people who have received the COVID-19 vaccine in the last 3 months. So it really is a protective vaccine against death in older people. And so that's why it's really a vaccine that we want boosting in older people. And you can see here that the recommendations reflect that. So it's recommended every 6 months in adults aged 75 years and above and aged care residents. It's recommended but considered every 6 months in younger, older adults and adults with severe immunocompromise, and you can consider it for any adult aged 18 above and younger children with severe immunocompromise. And the COVID vaccine can be given with other vaccines as well. Lots of resources on our website that you can look at. All right, I'm just going to have a sip of water. Okay, I hope you're all still with me. Now I'm going to talk about not a virus, but a bacteria. So just shaking it up a bit. Yeah. All right. So this is streptococcal pneumoniae. And you can see that invasive pneumococcal disease, they vary by age. Yeah. So you can see that again, like the other viruses, even though this is a bacteria, it affects the young and the old disproportionately. But in the middle cohort, it's actually people with underlying risk conditions. And this is a graph I'm sure you've seen many, many times, and it just shows that what happened when we introduced the vaccine in children. So when we introduced PCV, we saw a marked reduction of the 7-valent that were covered, that red line, and that's been kind of very, very low since. But then we knew that other strains were creeping up. You can see that blue line that was 13 non-V, and then we gave the 13, and then that blue line also went down. But then you could see the green line started creeping up, and especially in toddlers, they were getting disease, so it was changed from a 2+1. But then since then, you can see that the total number of IPD have actually increased and stabilized at a higher rate than when we introduced the PCV 13. So something needed to change. So you've been doing this for almost 7 months now. So it's 20-valent PCV for all children. So it's the only vaccine for children aged less than 18 years is 20-valent PCV. And since September, all doses of PCV should be that valent. and that is now incorrect. So I will show you in the next slide. So now the adult has just recently changed as well. Okay, so why did we go to 20 PCV? And this is just a graph that shows to you that the different colors. So these are the burden of disease. So and I just want to bring you to 2023 to 24, right? So 14% were those covered within 13 PCV. 15% were covered in the 15 valent that's in the private market, but not in the 13, and 12% were covered in the 20 valent and not the 15. So what happened was that by expanding from 13 to 20, we've increased from a 14% coverage of the serotypes that are causing disease to 41%. So still there is a gap, but this is a lot better than what we were protecting against. And this is the schedule. I remember that Aboriginal and Torres Strait Islander infants should have 4 doses, so that additional dose at 16 months. And if a child or an adolescent has a risk condition, then they need a dose of PCV 20 at diagnosis, so at any time, so that they get that 4 doses. But as the pneumococcal vaccines, the pneumococcal bacteria also causes havoc and continues to kind of have non-vaccine serotypes predominating in disease, so do, the breadth of vaccines. So we're very, very privileged in that we have lots of vaccines with wider coverage kind of being developed and being available. And the newest kid in the block is the PCV 21. And that's really important because when you look at adults, not children, but adults, you can see that majority of adults who have IPD have an IPD with that 21 valent PCV strain, right? Serotype. So you can see that the 21 valent here it's not 20 or 13 plus all these extra. It's actually quite different. It's an extended serotype and it doesn't cover these kind of initial PCV7. And it's because that this side of the serotypes are the mainly cause disease in children, whereas this side of the serotypes causes disease more likely in adults. Okay, so it's just been announced that a new simplified program will be commencing on the 1st of July 2026, where 21 valent PCV will replace this 13 plus 23 PPV, you know, how that we've all been kind of looking at and struggling and deciding, and it was just an absolute headache. So it's going to be 21 valent PCV to replace all, right? For Aboriginal and Torres Strait Islander, it'll be recommended from 25 years onwards, not from 50. So it's 25. And all other adults without risk conditions, it'll be recommended from 65 years. So it's lowered from 70 years. And further communications will come. So you're probably one of the first people that have heard about this. And there is a webinar series that NCERS is producing that will go into it in a lot more detail, and that's penciled in for late June 2026. But I just wanted to let you know on a couple of key points, okay? So a dose of 21 VPCV will be recommended regardless of previous pneumococcal vaccine status. So if your patient has received one, they're still eligible, okay? If they've received one prior, then give the 21 valent PCV 12 months after that prior dose. And all adults will receive only a single dose of 21 PCV, regardless if they become eligible in a different way. For example, they're solid organ transplant or other things. It doesn't matter. 1 dose for life. And if a child with a risk condition ages into the recommendation, they will be recommended a dose of 21 VPCV. So for example, if you're 16 years and you receive 20 PCV, when you turn 18, you're recommended 21. Okay. You'll have this slide so you can have a look at it, but there'll be much more information coming out. And this is just, again, a slightly busy slide, but it really is the data behind it, okay? So it shows that 21 PCV immunogenicity studies show it's generally equivalent to 20V PCV for the shared serotypes. So in the ones that are similar, it shows equivalent immunogenicity, right? It's better, obviously, in the ones that are different because the other one doesn't cover it. And it has a similar safety profile to PCV20. So it's a very safe vaccine, no difference in terms of APHIS. Okay, so just take home message. From July 2026, there will be no pneumococcal polysaccharide vaccines in the NIP for any ages. And I'm secretly rejoicing because I think conjugates are always better than a polysaccharide. Hey, protein better than sugar. Okay, so pneumococcal vaccine FAQs can be accessed, and then we'll get a lot of information on the adult program as well. All right, so in the last few minutes, I'm just going to talk about meningococcal B, and it's a bacteria. It's an encapsulated bacteria, so the theme kind of continues. It's not really regarded as a respiratory winter pathogen, but it is encapsulated like pneumococcal is. And it's been in the news recently in that there was a large Menby outbreak in Kent in the UK, and it was in a university setting. It was interesting in that it was a very rapid outbreak where they had quite a number of young adults who had visited this nightclub. I think that was kind of the initial starting point, and it was just that rapid emergence of a number of cases that was a bit unusual, and so they were really worried about that. And you can see here that this is like there's a line of people waiting, and this is all the people that were queuing for antibiotics. So they were all deemed to be close contacts needing prophylaxis, right? So that's a huge amount of people that they were treating to prevent secondary cases. And then there was another outbreak in Dorset, and they did a huge campaign to vaccinate young adults there as well. And then this was an awful story of an Australian, so a Perth student died overseas, and this was I think in April, where he developed an aggressive form of meningococcal B. He was just on a flight to Europe, and then within hours he passed away. His uncle's a prominent chef, I think, in WA, and so he was doing a lot of kind of information sharing around that. This is just kind of normal kind of infection microbiology, but we know that Neisseria meningitidis colonizes the nasopharynx of healthy individuals, and those at risk are the ones that are very, very close to that individuals. So if you have intimate contact, if you're in crowded venues, if you smoke, and you're in close living quarters. So those young adults are quite high risk. We also know that young children are at risk because, again, they do a lot of like secretion sharing, and people with complement immunodeficiency or asplenias, or those people who work with the bacteria in labs, the travelers to sub-Saharan Africa and the Hajj. And sub-Saharan Africa is this very unique place in the world in that it's called the meningitis belt, because we know that those pathogens really thrive in that area, and with the Hajj there's just overcrowding, and you can get meningococcal disease. And 10% of the general population are asymptomatic carriers, and we know that adolescents are the highest carriers, and therefore not only are they the highest for risk of severe disease, but they also transmit it to others. Okay, so we have 13 serotypes that commonly cause disease. And of those, A, C, W, Y, and B are vaccine preventable. And you can see the introduction of the different vaccine regimens and the reduction in meningococcal B notifications or cases. And you can see that there's this beautiful like sea of blue, and I don't know if it's beautiful, but it's a B for blue. So majority of strains that are circulating in Australia is meningococcal B, but we don't have a universal vaccination program for that bacteria. So NIP funded, ACWI and B We know that all infants aged 12 months and on 12 months should get the Nimenrix, and it's funded also in adolescents. And Bexsero is funded for Aboriginal and Torres Strait Islander children or for people with specified medical risks, but not everyone. And in adolescence, it's actually recommended, and it's pretty. It's been really like pushed because we know that this is a risk population, and but it is not NIP funded. But if you live anywhere outside WA or New South Wales, it's actually jurisdictionally funded in either most for all infants or they have an adolescent program. So Tasmania has just announced that they will fund all infants. Victoria has just announced that from the 1st of January 2027, they will give free Men B vaccines to year 10 students. So just for those people that also perhaps work on the border, it is a bit different if you cross border lines. Okay, lots of handbook resources that I find are useful to kind of have a look at. And again, as with everything else, we've got lots of information on our webpage, and I'd encourage you to have a look. And I'm actually done, Erica.
Thank you, At.
I will stop sharing.
Arch, would you like to go to the webinar chat box where there are some questions sitting? You can see that.
Do you want me to go through it, or do you want to ask specific ones? Or
There aren't many. We could just go through basically bottom up perhaps. If an RXV given to a 75 plus person in 2025 with a private script, so last year they got it privately, should they be given 2026 free RSV vaccine?
Yeah, sure. That's a common question. I would wait. We know that there's some really good data that shows that it definitely protects very well into the second season and pretty well into the third season. So keep that free dose for them for a couple of years later when we have a bit more data in terms of whether a second dose may be beneficial.
Yep. And then from Cam Wong, we've got a question specifically about the citation of evidence of the 6-month interval booster COVID-19 for people 75 and older.
Yeah, sure. I can put that in the chat. It's one of my colleagues, she Betty Liu and co, and she's done a really good study on that, and it's in an Australian study.
Yep. And Jason Harvey asks about giving multiple adjuvanted vaccines at once. I guess it's to the older person who might be getting fluad and a Shingrix or something
Shingrix,
like
yeah.
that.
Look, I think it's fine. I mean, we know that with Shingrix, it's pretty immunogenic and pretty reactogenic, so you're going to feel a bit like off, but there's no contraindication. Just really assess your patient and see how they may manage with it.
Yep. I think we've discussed the stock and expiry dates. Do you know, I have a question about the administration of flu mist. I
Yeah.
feel like I've read somewhere that basically you deliver the dose at the opening of the nostril, whereas I notice in a lot of illustrations in particular, the syringe is into the nostril and heading straight up. Do you have advice about where you actually have the
Yeah.
vaccine?
Yeah. Look, when you give it, you should point it a little bit more kind of lateral because we know that the nasal passage goes behind, right? But just slightly. But it's not like It's not like, what's it called? Those nasal sprays where you like stick it in and like
Yeah.
psh, you kind of
Right.
go it. It's highly absorbable. So it's only just that tiny bit in and
Yep.
then you squirt it in. Yeah.
Okay. Great. And just a question from my workplace today. A patient was concerned about having a denosumab Prolia injection on the same day as a vaccination. Do you have any comments on that?
Yeah, sure. So again, it's a question that I've been asked before. And no, we know that denosumab or Prolia is neither immunosuppressive nor a contraindication for vaccination.
That's good. I think we've covered the questions in the box.
Honestly, you guys are doing a great job, especially in regional Australia. And so keep up the good work. We really appreciate our GPs and our immunization nurses. And it's really about vaccination, not just vaccines that protect
Yeah,
people.
yeah, that's right. And actually, vaccination and vaccine hesitancy are big issues these days, aren't they? Um, and yeah, sometimes hard to counter the arguments of influencers and people with strange ideas.
Yeah, that's right. There's some concerning studies that have been done recently about parental concerns or parental views around vaccines, and when you compare 2025 data to 2024 data in Australia, it is a little bit more concerning, and so it needs to be an all of person approach, really. You know. It's really hard to kind of combat a lot of misinformation.
Yep. I can see one new question from BJ,
Mhm.
Handy. What do you do if a child sneezes after?
Yeah, sure. A child will most likely might sneeze, because you've just,
Yeah,
secreted something up its nose. But again, there's nothing to do. Again, it'll still be highly absorbable. You don't need to repeat the dose. Yeah. There is one thing that I didn't mention, and perhaps it is something to think about. It's more in the setting where, more in our setting, in the hospital setting, because it is a live vaccine and there is a theoretical risk of transmission, although it hasn't been documented. Usually, so in our hospital, we recommend that siblings of highly immunocompromised people, like people undergoing transplant or chemotherapy, receive the injectable vaccine, just because we know that there's absolutely zero risk. There's no theoretical risk of transmission, whereas with the nasal spray, because it is live, there is a theoretical risk.
got it. Yep. Thank you. Well, you're getting a lot of thank yous right now for your excellent presentation and slides, Arch. So, yeah, I'd like to thank you for being here tonight and sharing your expertise. It's greatly appreciated.